This is Dr. Vijay Agarwal welcoming you to this 31st episode of our international webinar series with ISQua and CAHO. So welcome you all. Good morning, good afternoon, good evening, depending upon which part of the world you are joining us from. We have people from more than 20 countries who are normally attending this webinar series. And today is again a very important topic, which is going to be covered by Dr. Kyung, and to moderate that session and to introduce him, we have Dr. Vasundhra Atre, who is a qualified cardiothoracic and a liver transplant anesthesiologist, as well as she has been a clinician par excellence, as well as an administrator, and has led many large groups of the hospitals in our country. She has co-authored a book on convert of incidents leading to action, which was released recently at the CAHO-Con. Dr. Vasundhra Atre was recently declared as one of the top women entrepreneurs in our country, one of the top medical faces in the country. It was a great honor, and she's a life member of CAHO, of course. And so without much ado, I will request Dr. Vasundhra to please introduce the topic today, that is measuring patient satisfaction and experience. And the speaker, Dr. Kyung, please.
Thank you, Dr. Agarwal, for the very kind introduction. So a very good day, like Sir said, we have different time zones with us. So a very good day to everybody. Welcoming you to CAHO's 31st webinar as part of the international webinar series. The topic for today, of course, is measuring patient satisfaction and experience. I have always felt that hospitals exist because patients exist. Patients are central to all activities and everything that we do in a hospital. But how do we know whether what we are doing is enough or right from the perspective of the patient? Today's webinar should help us develop strategies to answer these questions. And for that, please join me in welcoming Dr. Kyung, Professor and Chair, Department of Health Policy and Management, Seoul National University College of Medicine, Seoul, Korea, a postgraduate from Seoul National University College of Medicine, Seoul, Korea. He holds an MPH from the Seoul National University Graduate School of Public Health, Seoul, Korea, and a postdoctorate PhD in Health Policy and Management from the University of North Carolina at Chapel Hill, USA. With over 3 decades in the field of healthcare, he has held many prestigious positions and been the recipient of many honors, awards, and fellowships, the most recent being the Minister's Award, Minister of Health and Welfare, Seoul, Korea, and the 2020 Rothman Epidemiology Prize. He has contributed to book chapters, been a distinguished speaker at both national and international conferences, a mentor to doctoral students. He is also the co-editor-in-chief of Quality Improvement in Healthcare. His areas of interest in research include health system, decision-making in medicine and healthcare, population health, theory in health studies, and policy and program evaluation. And of course, coming to the area of our discussion today, he has done extensive research in the areas of patient experience and patient satisfaction. Dr. Kyung, without further ado, I would hand over the proceedings to you now.
Well, thank you very much for the kind introduction. I feel extremely honored to be part of this webinar and delighted to be able to speak to you about measuring patient satisfaction and experience, which I'm very passionate about. So my roadmap for today's talk. So I'll first start with why we should care about patient satisfaction and patient experience. And then I move on to the patient-centered approach to quality measurement with special focus on patient satisfaction with comparison to patient experience. So for this presentation, I'll just use the short form of patient satisfaction and patient experience, so PS, PX, respectively, just for convenience sake. And then I'll talk a little bit about why you should measure patient satisfaction, patient experience. But there's a fundamental challenge in measuring these things, and I'll briefly touch on this challenge. And then I'll introduce to you some of the measurement tools available. Because I was asked to give some practical tools and advice about the measuring patient satisfaction and experience. So I'll spend a bit of time on this topic. And then I'll conclude with some caution and concerns with regard to measuring patient satisfaction and experience. And so I plan to use about 30 to 35 minutes until this bullet point. But if there's some remaining time, and then I'll use South Korea as an example, as an exemplary case for measuring patient experience. So hopefully there's some time left for Q&A at the end of my presentation. So why you should care about patient satisfaction and experience rather than like provider satisfaction and experience. So first, patient-centeredness is increasingly recognized as a core component in healthcare quality. And this is the case at all levels of healthcare, whether it be clinic or hospital, and national or international. There's a bit different stream, but health system responsiveness is also different, but a closely related topic in this area. So health system responsiveness has been highlighted as one of the 3 goals of any health systems. So especially for cross-national comparisons, national and sub-national system levels. And then the third is, this is it's not a major topic, but I guess it's something to mention, worthwhile mentioning, because many of you come from hospitals, so the business case is also an important consideration. But I briefly mention on that as the third point. So as all of you may know very well, Donabedian's the seminal work of the definition of quality and approaches to its assessment. So here he highlighted that for any healthcare, there are 3 different components of healthcare. So the technical, of course, we are in healthcare to save lives and cure their disease. And so the technical aspect is definitely important. But he also mentioned that the interpersonal aspect and less of it, but amenities and other aspects of healthcare is also important. And in 2001, the United States Institute of Medicine has clarified that there are 6 goals of healthcare systems. So then patient-centeredness is one of the 6 goals. And in one of their the graphics, the patient-centered is literally center covering all these other goals. So in their document, patient-centeredness is defined as the healthcare that establishes a partnership among practitioners, patients, and their families to ensure that decisions respect patients' wants, needs, and preferences, and the patients have the education and support they need to make decisions and participate in their own care. As I already mentioned, WHO has listed the three objective healthcare system. And here, in addition to the basic goals of health attainment, WHO highlighted that responsiveness is another important goal, objective of healthcare system. And health system responsiveness is closely related, but somewhat different focus, because it has mostly focused on the system level. So the health system responsiveness is defined as aspects of the way of individuals are treated and the environment in which they are treated during health system interactions. So the key domains are involved are dignity, confidentiality, and autonomy, and prompt attention, and quality of basic amenities, and the choice of provider. And oftentimes, responsiveness and patient-centeredness are used interchangeably. As you can see here, OECD HCQI project. So here, in addition to effectiveness and safety, responsiveness and patient-centeredness is regarded as one as the same conceptual construct here. And more recently, OECD has this different name for Paris, because the OECD headquarters is located in Paris, in France. So the Paris stands for the Patient Reported Indicators Surveys, so the PRIS. And the Paris includes three different aspects. So patient experience, so the patient reported experience measures, and then PRIM, the patient reported instance measures for safety aspect, and then the clinical effectiveness is represented as the patient reported outcome measures. So the OECD is working to produce and collect data on the PLOMs and PLEMs, PROMs and PREMs for short. As I mentioned, the business case is also another important consideration. So in the US context, hospital value-based purchasing is now important aspect of any hospital administration, because for their Medicare reimbursement, patient experience scores measured in the tool, Hospital Consumer Assessment of Healthcare Providers and Systems, HCAHPS for short. Now, this score accounts for 20 to 30% of total performance score. So for from hospital administrator's perspective, the HCAHPS score is important for revenue, and so the business case is definitely important consideration for them. And not necessarily related to that, but many U.S. hospitals are now having this position, Chief Experience Officer, in addition to CEO or CFO, the traditional the positions in any corporate positions. So the Chief Experience Officer is in charge of this the patient experience and other aspects of quality and safety. So I have mentioned several different the aspects of patient-centered approach to quality assessment, but I just wanted to put together these things in one slide to just give you an idea of where these all things are put together in just one as one overarching framework. So here you can see the components of quality: technical, interpersonal component, and environment and amenities, following the Donabedian's similar work. And here, patient-centered approach to quality measurement, especially from the patient perspective. So here you can see that patient-reported experience measures. So patient experience is one of the terms included in our the title for today's talk, and then patient satisfaction is here. So these two are on the level of interpersonal component. But there are other things included in the Paris, in the OECD project. So the patient-reported outcome measures, PROM, as expected and desirable outcomes occurring from the healthcare provision. But there's another aspect that is undesirable, and those outcomes are those we want to avoid. But oftentimes, patient-reported instance measures can help us to identify potential adverse events in healthcare. So the PRIMS and PREMS are those the points included in the Paris project. But as you can see here, these two are more on the level of technical aspect, but these two are the patient satisfaction and patient experience are related to interpersonal component. And I should mention that the patient experience is more on the process, less of the outcome side, but patient satisfaction is more of the outcome side rather than the process. And I'll talk about that in a short. So in this slide shows the very brief comparison between patient satisfaction and patient experience. So I think that the best way to give the explanations of the differences between these two are just to show that the typical survey questions asked under these two different schemes of survey. So under patient satisfaction, we often ask the questions like, were you satisfied with the doctor you were allocated with? Or how would you rate the overall care provided by our medical personnel? And compared with these questions under patient experience, we would ask questions like, during this hospital stay, how often did nurses treat you with courtesy and respect? And during this hospital stay, how often did the doctors listen carefully to you? So I think you can feel some differences between these two types of questions. So one is these questions are more of outcome, as I mentioned in the previous slide. And patient experience is more of a process measure, because these questions are related to so asking what has come out of care. So as you can see, the outcome is just like changed the order. So what has outcome of care? So were you satisfied as the outcome of that care? But under patient experience, we ask, did things happen as desired? So in this case, the nurse is treating patients with courtesy and respect is the desirable thing. So whether this thing happened and or for the second question, doctors listening carefully to patients, that is the desirable thing. So whether that happened or not, so that is basically what's being asked in the patient experience. So I think now it has become a bit more clear than before. So as I keep mentioning, so the patient satisfaction is outcome, and but for the aspect of nature of measurement, patient satisfaction is sort of rating. As you can already notice that, how would you rate? It was the question asked under patient satisfaction. But here, under patient experience, patients report whether that happened or not. So, so rating and reporting, it may be just a semantic issue, but I think it's important distinction to give different names, rating and reporting for patient satisfaction and experience, respectively. So, as you can imagine, patient satisfaction has many advantages in terms of measurement, because it has more generic. So you can just ask one question: were you satisfied with our care? So it can be very generic. Of course, it can be more specific because you can ask about the food and the noise level or whatever. But overall, it can be more generic. And so you can ask fewer questions and better suited business case because it has the item of satisfaction. But for patient experience, it can be relatively specific because we need to ask whether specific things happened or not. So because of that, the questions under patient experience are less prone to reporting heterogeneity because satisfaction has many different components coming in, like expectations of patients. But here, that's less a possibility. And also, patient experience is advantages in terms of it can be more actionable because the patient quality managers can understand what is missing in their care in their hospitals. So that more actionable is another great advantage. And also, from my own experience in South Korea, the doctors hate patient satisfaction here in Korea, at least. But patient experience is gaining more support because they also agree that this is important. But for patient satisfaction, doctors may feel like they are just like providers of commodities. So patient experience, in my view, seems to gaining more greater support by professionals. I think I spent too much time, more time than I had expected, so I just move quite properly. So then let me talk about why should measure patient satisfaction and patient experience. So I think definitely one reason is epidemiological approach and the quality improvement purpose, and political reasons are another important reason. So, but of course, these three are all interrelated. I'll briefly mention each of the topics. So we need to know whether what is the level of patient satisfaction and experience, and so for epidemiology is important the approach to knowing what level of the patient satisfaction and experience. So measurement is the first step in any scientific and analytic endeavor, and we need to know magnitude of problem and the distribution and variation and patterns and trends, policy impacts. So all these are related to the epidemiologic approach to measuring patient satisfaction. And one of the canonical example is seen here. So the HCAHPS shows the distribution of scores under each domain. So here, communication with the doctors, the scores are shown by region and bed size and teaching status and ownership and control in the US hospitals. And then we can also look at whether patient characteristics has any important differences, make any differences in health system responsiveness. So here is shown that wealth levels can make differences in their health system responsiveness. Of course, we want to measure part of patient satisfaction and experience for quality improvement purposes. So Peter Drucker, as well known, the expert in administration, said this: if you can't measure it, you can't improve it. So measurement is another important step in any QI activities. So measurement itself is often important in making any differences, but feedback and public reporting and tying to reimbursement are another important ways to improvement quality using measurement. And I wish I had more time to say something about this theoretical the pathways, but I'll just skip that for I think I can share these slides later, so I just skip that. Maybe you can just look at this paper, very nice paper about how measurements can lead to quality improvement, from a theoretical perspective. But I think political reasons are also important from my own experience in South Korea, because numbers can have power by making invisible visible. So also by making numbers from measurement, norms and cultures can change. So we can justify and mainstream patient satisfaction, patient experience as an important topic in our healthcare quality debates. Also, resource mobilization becomes possible by measuring patient satisfaction and experience. And also by measuring patient experience, we can narrow down responsibilities to specific actors like doctors and nurses. Also, oftentimes, equity concerns may also prompt actions by politicians and the policymakers. But there is a fundamental challenge in measuring patient satisfaction and experience, because patient is the source of information, and patient is probably the best source of information for patient satisfaction and experience. And also, they are the only source of information from this, because we can use the analogy to pain. So for pain, there's no good proxy measure for the measuring pain, because it's the typical example of the patient-reported outcome. And because of that, there are many ensuing issues. So the general issues of a measurement, reliability and validity, are often more problematic in measuring patient satisfaction and experience. And also, patient satisfaction and experience can be affected by patients' characteristics. For example, healthier patients tend to have a lower expectations and better patient satisfaction scores. Closely related to this issue, but the measuring patient satisfaction and experience is has another important issue of the subjective nature, because reporting heterogeneity is often an important issue. So, for example, younger patients have often generally less generous about reporting patient experience. So they very high level of expectations about patient experience. So then they tend to give poorer patient experience scores reported, although there are no important difference between younger and older patients. So I wanted to make this presentation and slides very useful to you who may have come very different settings and backgrounds. So these two sources can be very useful. I feel I find these two sources extremely useful in contemplating and considering and implementing patient experience surveys. So these are the links. And if you click this second document here, it says that so for any measurement tools in patient experience and patient satisfaction, what they are saying is, although many tools are available to measure person-centered care, there is no agreement about which tools are most worthwhile. Then there's no silver bullet or best measure. So they introduce 160 of the most commonly researched measurement tools. So if you click this part, then you can see many different survey tools, measurement tools and they have different columns, types of tool and target, context, and country of development and tested in. So I just scanned and this slide. So as you can see that what are the measurement tool names and then descriptions and category and the major concept and the context and the countries where the measurement tools were tested. So I think I advise, I would like to recommend you visit this website and click this, and then this is this would be a very useful source of information for you. Okay. But there are many practical considerations. So when do we measure patient satisfaction or patient experience, whether it be before discharge or after? And if after, how long after? Whether it's like 2 weeks after or 3 weeks and 8 weeks? And what domains, whether generic or condition specific or number of items? And then duration of survey. Oftentimes, longer survey is extremely hard to implement. And then mode, the mail, telephone, mobile, and mix of these. And also population groups are important considerations. And then technological diffusion and adaptation. I mentioned this because now the older people are more accustomed to using the smartphones and internet. So this has changed the landscape of measuring patient satisfaction. So I think this issue would become more relevant in the future than now. And also acceptability and confidentiality issues are also important. Of course, from the measures perspective, cost and sustainability is another important topic. Caution and concerns. And oftentimes, the measuring may end just like they can serve as an excuse, like saying that, oh, we have done something about the patient satisfaction, but measuring is just one first step, although it's important, but it's not the only way. So another way of saying that is measuring is a necessary condition for improvement, but not a sufficient condition. And oftentimes, especially when incentives are involved and the reimbursement is involved, the gaming by providers and hospitals is often an issue. And also, if we measure some aspects of care, and then the other aspects of care can be sacrificed, as the literature suggests. So there may be some unintended consequences. Do I have some time left? Just briefly scan the South Korea as an example.
Sure, Dr. Young.
Okay, let me go as fast as I can. Okay, so South Korea implemented patient experience assessment since 2017. So I was part of the development, the initial phase of this, the model development for this exercise. Then just give you a brief background of the South Korea's healthcare system. So it has developed and expanded very rapidly, fueled by national health insurance in 1989. So it helped improve the access, technical aspect of care quality and amenities, but interpersonal and relational aspect of quality care is often sacrificed, such as patient experience. Currently, it was implemented in 2017 and expanded to smaller hospitals in 2019 and 21. Is now implemented by the Health Insurance Review and Assessment Service under National Health Insurance. And it was a benchmark of the US Hospital Consumer Assessment of Healthcare Providers and Systems, HCAHPS. And currently it's only on inpatients discharged from general hospitals. And it's within, survey is conducted within 8 weeks after discharge. So the questionnaire is about patient experiences during hospital admission, using 21 proper questions via telephone-based survey for now. So this is one of the patients I surveyed in a qualitative research before implementing the survey. So so most doctors do not have time. I cannot have adequate time to talk with them. My doctor explains only very briefly, and the conversation ends too quickly. I could not remember questions I had in mind. It's only after he disappeared that I recall them. And most doctors do not answer my questions well. What makes them so busy? They avoid talking to me, keep distance, and remain calm. So one of the, actually 2 patients talked to me like this. But that was pretty much the general across other the patient groups. And the reason is because Korea has one of the highest doctor consultation numbers among OECD countries, but with fewer doctors than relatively fewer doctors than other countries. So as you can see that the doctor consultations per any doctor is much higher than any other countries within OECD countries. So this is reflected in patient experience surveys. So patients are extremely negative about the doctor domain in the patient experience survey, as you can see here. So as you can see here, you see some Korean letters here. So the doctor, only 31% of respondents said that their doctor, they had enough opportunity to talk with the doctors as top boxes percentage. But the situation is not that different from the nurse side. So Korea ranks lowest in terms of the number of nurses per hospital bed. So as you can see here. So I used data from patient experience survey to see whether nurse staffing level has any relation to patient experience score. So as you can see here, there's a clear pattern of declining patient experience score with the lower nurse staffing level or the nurse domain, the 4 questions in the nurse domain. But also the hospital's number of hospital beds can have impact on patient experience scores. But there's important differences between nurse domain and doctor domain. So as you can see here, bigger hospitals, larger hospitals tend to have better scores in the nurse domain. But smaller hospitals do have a better scores. Some hospitals do have a better scores, although they have a larger variation. But for doctor domain, the larger hospitals do not necessarily show that better the patient experience scores. So this is one way of showing that the epidemiological approach to patient experience can help us to identify which domain is important from the hospital QA perspective, and the more actionable the items from the QA part. So the Korea's patient experience assessment, where it stands now, it has definitely contributed as a catalyst for enhancing patient experience in South Korea. So it has garnered considerable attention from media and hospitals with public reporting. And the hospitals have started working hard to improve patient experience and seeking ways often to increase their score, not necessarily patient experience per se. So there are some critics to this exercise because the gaming and blaming and shaming for the lower ranked hospitals. And as of now, less attention has been paid to structural constraints for patient experience, such as healthcare workforce, as you have seen the close relationship between nurse staffing level and patient experience. And currently, because of the cost and sustainability issues, we are considering converting from the telephone-based survey to mobile-based survey, because the diffusion of a smartphone is now 95% for even older people. So I've recently conducted a research on this aspect, and so now we are pretty convinced that the mobile-based survey is the way to go for the future. So here's what I have to say. Thank you very much for your attention.
So thank you, Dr. Young. That was a very helpful presentation. And I'm sure the measuring tools that you have shared will be useful. So we are left with time enough for question and answers. And I have a whole lot of them which are already there in the box. So I'm going to jump into them and look forward to your answers. So I have an anonymous attendee who has asked how to calculate total patient score in feedback if they do not put a score for some services as they have not received all of the services.
Okay.
So for example, you do a survey and you only
Right.
have some responses, but not all of them, because
Right.
patients may not have availed all of the services. So
Right.
how would you calculate that?
Right. So this is from a practical perspective, this is often the case. So this is another reason why we want to keep the measurement tool as concise as possible. So if many patients reported to some domains, but not to other domains, then they're missing data from a statistical point. So then it's really challenging to calculate the overall score. Definitely, this is an issue. So we have there's no one best solution to getting around this problem. So I would say that either you can force the patients to answer all the questions, or to increase the sample size as much as possible to so that the missingness is not a less of concern. But there's no one best answer to this problem.
Right. Thank you. The second question is from Elizabeth Johnson. She asks, which specialty is more relevant to prop and trim, and how long?
Great. I think this is a very important point, because countries may have different priorities. And I would say that, so for example, like end-of-life care, for just for the example perspective. So there's no one best measure of outcome, clinical outcome, to measure the effectiveness of clinical care. Of course, you can imagine like the spiritual aspect of good quality for end-of-life care, and palliative care and pain control. So pain control is definitely one of the good the PLOM from. But oftentimes the patients and their family members and relatives, they experience whole lot of different issues, different from their clinical outcomes. So, but think about the knee surgery. So the patient-reported outcome measure is definitely important, because you go through the knee surgery just to in order to recover from the knee pain, or the not being able to climb stairs. So the outcome measure is more relevant, but also there are many aspects of care that we put more the clinical aspect, the technical aspect on, but there are many other aspects of experiences also important. But I think that for any aspect of healthcare, PROM and PREMS are not mutually exclusive. I think I should mention this very clearly. So this is not a matter of choosing one over another. So it's more of the combination of the focus to which PROM, whether PREM, how the relative weights is given. That is
all learned a lot about patient experience and satisfaction, and most importantly, the difference between the two, because that is always an area of confusion. So thank you so much for everything. Dr. Lalu, over to you.
Thank you. Thank you so much, Dr. Young, for that brilliant presentation.
Thank you.
And thank you, Dr. Vasundhra, for moderating it so well. It really, is a wonderful session and excellent feedback. If you go through the chat box, you'll see the feedback from all over the globe. And my apologies, I could not join in the beginning. And when I joined in, there were about 563 participants online. And with over maybe 30 hospitals, with about 40, 50 people connected from their boardrooms. And that's the reach, Dr. Young. And thank you so much for sharing your precious time. We look forward to meeting you very soon in Seoul. We are planning to come.
Oh, right. I would like to welcome you all to Seoul in August.
Thank you so much. And a large contingent of about 25 of us are joining you at Seoul. So really look forward to meeting you. Thank you so much, dear friends, for joining this session. I take this opportunity to invite Dr. Anil Kumar Chilimuntha, the state chairperson of Gujarat, to honor our speaker for the day, Dr. Young, with a virtual certificate. Over to you, Dr. Anil Kumar.
Thank you, Dr. Lalu. And thank you for Dr. Young. You have given a very apt and applicable topic that you have elucidated throughout this time. We really appreciate you and thank you on behalf of CAHO. And we look forward to hearing from you more and more, and then interacting with you more and more in the coming days. Thank you so much, sir. And we wish to give you this wonderful certificate on behalf of our President, Dr. Vijay Agarwal, our Secretary, Dr. Lalu Joseph, and also the Chief Executive Officer, Dr. Carsten Angel. And we sincerely thank you and appreciate you for all the wonderful way in which you have talked to each one of us. It was something which is very inspiring, and we have learned a lot. Thank you so much.
Thanks a lot. Thank you. So thank you, dear participants, friends all over the world, for taking your time and joining us today. We really appreciate you taking your time and for being part of this journey of CAHO to spread the wave of quality, patient safety, and accreditation. We are in this together. We are one family, and this country needs us. Jai Hind. Thank you.